Okay, so today I'm really honored to actually be here, and this is Darren's brainchild. So I have to admit to that, because Darren actually had us do Tuesday topics on COVID probably about a year ago right now, where we just sort of talked about, oh yeah, this is COVID. It was all brand new, and it was Darren's idea that we held this Tuesday topic, and it was, now I look back and it was incredibly timely, and we provided an amazing wealth of information. So our brainchild Darren came up with another idea, and that was for us to create a Tuesday topics around the vaccine. And I have to admit that if ever in our lives we were involved in an ethical, political, healthcare environment, it's now, and this is it. And so I really want to challenge all of you to sort of think about what we're talking about today. You all, because you're healthcare professionals, will probably be asked about your personal opinion with respect to the vaccine. And what we want to do is just arm you with some information for you to think about. And we're going to do that in a couple different ways. So if you can go to the next slide, please, Molly. We're going to look at the vaccine and best practices through 4 different lenses. Each one of us picked a sort of a topic. This is a huge topic with respect to the vaccine. So each one of us picked sort of our favorite aspect with respect to the vaccine. So I'm going to start us off by talking to you about sex and gender equity when it comes to the vaccine. We're also going to have a discussion about ethics and vaccine distribution. We'll also have a discussion about good neighboring and social responsibility when it comes to the vaccines, as well as we'll end with underrepresented minorities and their role with respect to equity and vaccines. So again, what we want to do is really open the dialogue. We would love it if you asked questions. We understand that all of us become kind of mice with respect to asking questions when we're in the Zoom platform, but this is such an incredibly important topic that really would be best if we were able to do this live in person and engage in a dialogue. So let's try and do our best effort with respect to engaging in a dialogue. So with that, Molly, let's go for the next slide. So my lens and my life and my passion have to do with sort of understanding the differences between sex and gender. In my academic scientific career, I focused pretty much solely on the role of sex and its impact on different disease modalities. And then I transitioned to understanding and beginning to appreciate the role of gender. And so when we're looking at data, I want to encourage all of us to become incredible scientists when we look at data, because this is the first disease state that I've ever seen that actually differs by both sex and gender. And so I'm going to try to help you understand what I mean by that through these next couple of slides. So when you look at a data slide such as this, it says the US COVID deaths, and I represent this by sex. If you look at the actual title of the slide, it says US COVID deaths by age and gender. That would be an incorrect use of the terminology gender, because what they're representing here is by sex. They're representing COVID deaths by sex. They're comparing female sex to male sex. And one aspect that I want you to really appreciate with respect to this slide, and I could show you 25 other slides that look very similar to this, and that is that even as women age, there is still a sex advantage, meaning that women die less frequently of COVID than do men. That's important because when we talk about sex hormones, what we're seeing here with these data is that independent of sex hormones, because as women age, our estrogen levels go away, independent of that, independent of the sex hormones, there's still a sex advantage with respect to survival in COVID. So I'll talk more about that in a second. Next slide, please. So let's again define what we mean by sex and gender. Sex refers to specifically the biological sex. And when I refer to sex, I'm talking about the sex chromosomes and the sex hormones. So females sit with 2 X sex chromosomes and a male sits with an X and a Y sex chromosome. And then in our hormonal milieu, our estrogen is greater than testosterone, and in a male's hormonal milieu, testosterone is greater than estrogen. This is completely different than gender. Gender is a social construct. It refers to lifestyle, nutritional factors, exercise, perceived stress, smoking, disease perception, health-seeking behavior, use of health care, decision-making. All of these are gender activities. They are not sex-based activities. And so when you look at my next data set, you'll understand that there is an important distinction with respect to specifically COVID between sex and gender. So let's look at the next data slide. So what we're seeing here is, again, the title of the slide is COVID, and this is with respect to Indiana, but I could show you any state within the United States or an aggregate of data from the United States, demonstrating that COVID-19 confirmed cases by mortality by sex. However, that's also a misnomer with respect to this slide. And that is that when you look at the number of confirmed cases of COVID, female or a female gender, his higher number of actual cases of COVID versus the mortality, which is based on sex, female have a lower mortality when it comes to COVID. And why I say this is that there are so many aspects of female or a female-like gender, which is females or a gender-like female are more likely to engage in activities such as be healthcare providers on the front line, so they're more exposed to COVID. They're also more likely to seek healthcare. They're more likely to seek out testing for COVID. There are a whole host of actual behaviors that are involved in that female-like category that are associated with the increased number of confirmed cases of COVID that you see in a gendered, sort of in a gendered way, where the mortality is skewed by sex. So hopefully I was able to differentiate those two. This is, again, the very first time I've ever seen any disease process that's been broken down and is so disparate with respect to these two different categories. And I think it's relatively exciting. So next slide. So here I'm going to also sort of highlight why this might be. When you're looking specifically at the mortality, what we see is it's a sex-based effect where female sex causes you to have less mortality associated with COVID. But when you're looking at gender, you might look at pre-existing comorbidities such as heart disease, which can be differentiated by gender, hypertension, which can be differentiated by gender, diabetes, which can be gender and or sex, as well as a whole host of cancers, which can be different based on different lifestyles, perhaps more smoking, which might be more male-like, which then increases overall cancer risk, and you can see the parallelism there. There's also a difference with respect to high-risk behaviors such as social isolation, smoking, alcohol use, and certain occupational exposures, where in this case, they're indicating that men might have more of those activities than do women. Specifically related to sex, though, there is a significant difference with respect to the innate immune response, and we'll talk about that in more in just a second. So we'll go to the next slide. So why is this so important, especially when it comes to the vaccine? Well, for the longest time, the U.S. Food and Drug Administration actually indicated that women of childbearing age should be excluded from drug trials. So that means that most of, and actually this is just, it indicates women of childbearing age, but it's also with respect to even women in general. There have been a whole host of different types of drug trials that have excluded women. And the reason they've excluded women is because of hormonal cycle and a whole host of different factors. But because of the Office of Women's Health and now the new mandate from the National Institutes of Health, they are now as a mandate to include women with respect to all data trials. And specifically with respect to the COVID vaccine, this allowed women to participate in the COVID trial. And also that they also want to make sure then that data is disaggregated so that you're actually able to look at the data, for example, on the COVID vaccine trial that differs how women responded to the vaccine versus men. But what you'll see is most of the journal articles that actually say that there were equal numbers of men and women in the trial, they don't disaggregate the data with respect to how women responded to the COVID vaccine differently than to the men. So we'll talk more about that in just a second. Next slide, please. And why is this important? Well, women exhibit a greater immune response than men do. And this has to do with a whole host of different factors, specifically factors that are on the X chromosome. And there's also a factor that is called incomplete activation of some of the genes on the X chromosome, which actually enhance our overall response to immune challenges. So biologically, the female sex, again referring to the X sex chromosome, we have a heightened immune response. And the reason this has become so important is if you were not to include women in the COVID vaccine trials, you might miss the fact that women might have a heightened response to the COVID vaccine if they weren't included in the overall trials. And that becomes incredibly important again when you look at these data. So next slide. Again, sex steroids even have a differential effect on immune challenges, such that estrogens, when estrogen is higher, females have a higher response to overall immune pathways, as well as estrogens actually promote specific gene expression profiles. And phenomenal to me is that estrogens actually downregulate the very enzyme that takes up the COVID into the cell. So estrogens downregulate this angiotensin converting enzyme 2, or SARS-CoV-2 receptor, which is the same receptor that takes COVID and puts it into certain cells within your body. So there is a host of data now to demonstrate that women, specifically when estrogens are higher, have a lower incidence of COVID invasion into the cells. Furthermore, women are much more responsive to microRNAs, and that's the type of vaccine that is now being provided. It's a microRNA platform. So by all incidences, women should have a much higher incidence of response to the COVID vaccine than do men. So next slide. So this is just a sort of a cartoon to demonstrate that whether it's the infection or the vaccine, the infection or the vaccine enters into the host, which would be the male or the female. For women, we have a higher level of X sex chromosomes, which heighten our immune response. We also have higher levels of estrogen, which heightens our immune response, which provides us with a higher immune response, which decreases the overall mortality associated with COVID and enhances our response to the COVID vaccine. Men, on the other hand, are slighted by this in the fact that they don't have as many X sex chromosomes. They don't have estrogens higher than testosterone. They have a diminished immune response, and therefore they have an increased prevalence of death and a lower response to the overall vaccine. So next slide, please. I'm almost done. So I just took data from the New England Journal of Medicine, and this is one of the COVID vaccines. And I wanted to highlight these data because they also set the stage for the next presentations. And that is, if you look at the demographics, and I want you always, whenever you look at the vaccine trials or anything, I want you now to look at it with a sex and gender lens. So what you'll see here is that in this specific vaccine trial, they took an equal number of males and females. But look at the number of Caucasian people versus those people who are of ethnic diversity. That is astoundingly frightening as far as I'm concerned. And so I know that our panel members will address this specifically in the next presentations, but look at these data. Additionally, what I want you to look at with respect to this is if you look at the age of the participants in this specific trial, and this is one of the larger trials, the age ranges between 16 and 55 years old. That means that postmenopausal women are likely not included in this trial. Now, again, the data are not disaggregated for estrogen status, so we don't actually know those data. Those data probably don't even exist because the age of the women included in this trial were so incredibly young. They have a very small percentage of people who are greater than 55. So for those of us who are greater than 55, we can assume that this virus or this vaccine hasn't necessarily been vetted in those of us who are greater than 55. Additionally, if you look at the number of people from different countries, predominantly in this trial, it was individuals who came from the United States. But again, that would suggest to me, that if you were from a different country, such as Argentina, Brazil, or South Africa, you are not very well represented in this specific trial. So again, whenever you're looking at these vaccine data, especially if you're asked to weigh in on the scientific validity of the data, I want you to be able to interrogate the data with some level of knowledge as you begin to do that. Next slide, please. And probably one of the biggest disservices to me when I'm looking at these data, and it wasn't just this one, which was in the New England Journal, but some of the other trials as well. This is the data that they show that the efficacy of the vaccine. And what you can see is, again, it is not disaggregated by sex. I would absolutely love to know, of those individuals who received the vaccine, what percentage of them were women, and what was the female response to the vaccine, and how did that compare differently from the men? And that's not what we're going to be able to find in this data set. So again, I think that those are some important pieces of information. I was recently talking to a physician who recommends breastfeeding for women who obviously need to breastfeed. The question is, does the vaccine get into breast milk? There's not a lot of data around that. So, and again, those individuals were probably not included in a lot of these trials. Women of childbearing age and or women who were thinking about becoming pregnant and then received the vaccine, what was their response? All of this information becomes very, very important to different subcategories of individuals, but is information that we don't have enough information to be able to provide informed and knowledgeable discussions about this. Next slide. I think I have one more. Oh, no, this is back to that. So this was just sort of a primer to be able to tell you that there indeed are sex and gender differences with respect to COVID mortality and incidences. There's also a significantly higher response from women following the vaccine. When I've gone in and looked at data sets that suggest that women are more prone to having adverse reactions to the vaccine. And again, this comes down to our biology with respect to our heightened immune response, as well as our sex hormones. So with that, I can go ahead and turn it over to our next panel member, which is going to be Connie. And you can get rid of my slides, Molly, and present Connie's slides. And then we'll take questions at the end. So thank you.
So let me just interrupt quickly. I realized that we didn't introduce who's on the panel here. So we have Connie Perry. Connie, you want to say a little something about yourself?
Hi, I'm Connie Perry. I'm a philosopher, bioethicist by training. I'm a certified clinical ethics consultant, and I'm in the Department of Health Administration.
Wonderful. Kim McClellan, you want to say hi and introduce yourself to the folks?
Sure. Hello, everybody. So I'm Kim McClellan. I'm a nurse practitioner, also normally clinician in the clinical community setting. And my latest fun is working at the COVID testing site for Drexel.
Wonderful. And Dr. Ebony White, you want to introduce yourself?
Absolutely. Ebony White. I'm in the Counseling and Family Therapy Department. I am a behaviorist, a clinician by trade, and excited to be here.
Wonderful. Thank you. Connie, take it away.
Okay. Hi. So what I'm going to do is I'm not going to answer what is the most ethical way to distribute the vaccine, because I think, you know, I'm not sure what the answer is. But I'm going to provide you with some of the tools to do the analysis, and then hopefully we can have a good discussion afterwards. So I'm going to introduce you to some of the theoretical concepts that underlie the question of how to fairly and justly distribute the vaccines. And I'm going to, next slide, please. I'm going to begin with John Rawls' fair equality of opportunity principle. And I'm going to do this just because people always say, well, you need to distribute vaccines fairly. And fair is a word that we use pretty often, and yet it's deceptive because its meaning and implications are ambiguous, and it's actually fairly complex if you try to apply it in practice. For example, a strictly equitable distribution system for the vaccine, say first come, first serve, would result in a very unjust vaccine allocation system, right? So let's see, Rawls argued that fairness must include what he called fair equality of opportunity, with more beneficial positions open to all, and especially those who are most affected by the inequalities in society. What Rawls is attempting to do, or was attempting to do, was to incorporate the ability to address injustices within society, and a way to redress the impact of those injustices. And so that seems like a pretty timely thing for right now. So instead of a static sense of fairness, what you get is a sense that can challenge structural injustice. The challenge then is to constantly question the fairness of the opportunity. You know, we assume that the opportunity is fair, but you have to get in the habit of constantly stepping back, listening to diverse voices, reassessing, is this really fair? And encourage those that are made vulnerable to rise in the system, and thereby making their voices more pronounced, and improve their ability to participate, and such. So it's not, next slide, please. So Rawls' system is not strictly a principle for distributive justice. As we'll get in later, there are different types of justice, but if we apply it to vaccine distribution, we can see some helpful ideas. So you can see a just distribution proposal should include the creation of a sense of voluntariness. You know, that's usually the easiest way to, you know, like the starting point for distribution of limited or scarce resources. You know, is there anyone here that doesn't want it? Right? And then, and we'll get back to that point later, but and then you get into questions about realistic access. For example, with the vaccine, you know, individuals living in rural areas, indigenous populations, you know, you have vaccines. The first two that were available have to be kept really cold. Well, you know, if you're talking about people that live in a desert climate, away from major roadways and such, this can create a real obstacle to access, and we're seeing that as a challenge. You can get another point from Rawls is this idea of a fair process for prioritization and distribution. You know, personally, I was really blown away when I discovered that the city of Philadelphia didn't include EMS and first responders in their, you know, top tier of 1A prioritization. You know, if you look at the list of, you know, healthcare professionals that are dying, many of them are, you know, in that population. You know, they can't really control the environment. They don't know what they're getting into, and it's also the same population that had significant problems getting access to PPE and such. So stepping back and relooking at that, you know, are we treating equals equally? Equal treatment based on the assessment of the risk and the significance. So the risk is the probability of being exposed to the, you know, to the harm, and the significance is the degree of harm, right? So you want to look, you know, this is why individuals that have the highest risk of death are being given higher priority. and treating that. But then you have, I have a colleague in California that realized that individuals with disabilities were not being, who had similar risks of complications from COVID and such, were not being treated the same as individuals without disabilities in their prioritization system, and that can be a problem with regard to fairness and ethics. Rawls' system doesn't address social impact, doesn't address the harm principle, going back to, maybe someone refusing to get the vaccine could cause harm to other individuals, or refusing to wear masks and such, and it doesn't address the role of efficacy and utility. I mean, it may be the fairest to give, to address inequities in rural populations, but that might not give you the biggest bang for the buck with regard to addressing the pandemic. And so that has to be considered. Okay, next slide, please. Okay, so now back to basics. So I mentioned there are different types of justice. So there's comparative justice, and that's where you compare one, individuals. The biggest thing is distributive justice. So you're you want to distribute an entity, or and here vaccines, and you don't have enough vaccines for everybody, and so you have to compare and decide who gets the vaccines first. And then there are non-comparative aspects of justice, and so that can get into questions about certain rights. So we had the issue with Moderna saying that they were going to vaccinate all of their employees, and people said, well, that that seems unfair, when there are people that are at higher risk of both exposure and harm. And Moderator said, well, you can distribute the vaccines that we're giving to you for the general population, but we're holding some in reserve, which are our private property, our right to private property, and we can distribute those as we see fit. So the question becomes about, the rights. There are also things with like the right to life. Initially, this isn't vaccines, but there was a proposal when we thought we were going to run out of ventilators, that we would take ventilators from individuals who are ventilator dependent because of other conditions, like just that's how they live, and give them to quote unquote more deserving individuals, which would be a violation of both right to property, but also right to life for those individuals. So you have questions of non-comparative rights. And then you also have issues of compensatory issues, and that's where you have, let me get into the next slide, please. I think you have, with compensatory issues, you have issues like individuals who put themselves at risk in order to care for others, and that should be factored in both from a compensation for the risks that they've taken to help other people, and also from a utility standpoint, that they're needed to help other people, and that giving the vaccine to them helps more than the individual receiving the vaccine. There are also issues with compensation should we, and there have been some proposals that, individuals, should we withhold vaccines from individuals that refuse to wear masks or that continue to engage in group activities with other individuals despite public health warnings and recommendations, that kind of thing. So, okay, I have this as vaccines and brownies. One of the things you need to think about is what is the thing that you're distributing? So here we're talking about vaccines that's different from, say, distribution of something like a cake. So the classic just distribution, example is where here we'll say a brownie. So you have brownies and you want to know how to fairly distribute them among individuals. So you choose one individual to divide the brownies up into squares. And then the person who does that becomes the last person to get a brownie, right? So that controls for self-interest, right? And it creates an incentive for the person who's doing the distribution to create the fairest method. That's not really going to work here with vaccines. The other thing with brownies is that you can create more people you have, the smaller your brownies get, right? The individual brownies, but you can't do that with vaccines. And the other thing is that the stakes are higher. So there's a similarity in the need for trust. We have to be able to trust the individuals that make the brownies, that they're not, putting laxatives in our brownies or other things. Similarly, we have to encourage the public, encourage trustworthy methods so that the public will trust that the vaccines will benefit them more than harm them and such. But the other thing with the vaccine is it's different from, say, distributing scarce goods like organs for transplant, in that the main thing that you're looking at here is time. You will, if you wait and avoid and that's the big caveat, avoid getting COVID, you will eventually get the vaccine. Which is not always the case with distributive justice in medicine. All right, so anyway, for next slide, well, I'm going to wrap up. And next slide, I talked about this, and I talked about that a little bit. Next slide. Next. Okay, so there are some things that we have agreement on. One is that there's a typo there, but that most people find the risks of COVID significant. And so most people would like something that will prevent it. Most people don't want to hurt others, especially their loved ones, and most people are interested in reducing the threat as soon as possible. Next slide. So this leads to a general agreement that we should prioritize those at greatest risk. So those are the people that we do have not 100% agreement, but we have some consensus that that's the way the prioritization should go. And that we should try to avoid loss of life. We should and then the next thing is that I think that we need to have, when we try to do this, and that's where the difficulty is, we should have ongoing review and the ability to adjust to improve our ability to reduce risk to those at greatest risk and those that are most vulnerable, and come up with the best outcome. And if we notice ongoing inequity, injustice, unfairness, adjust to try to address that. Next slide. I think the next slide. So we agree that the process used in order for this review to occur and to have trust build, things have to be transparent, clear, and manageable. We have to compensate with regard individuals for the costs of development, manufacture, and distribution of vaccines so that we can maintain that supply, and that we need to recognize those that expose themselves to high risk, and prioritize those that are going to have serious outcomes. And I think
Thank you, Connie.
I think that's it.
Great. If people have questions, you can pop them in the chat and we'll circle back at the end if we have time. Dr. McClellan.
Okay, hello. Sorry about that. I was off the page for some reason. Okay, yeah, so I don't have slides. Sorry about that. I was actually going to try to get a picture together of my kids not sharing well, but then when they were little, but I just couldn't work that tech so quickly. So anyway, but that is a little bit of the idea of my portion, and then I'm going to lead you into Dr. Ebony White's as well. Is that the whole idea of this kind of good neighboring principle. I've had well, depending on what day it is, I've had either the fortune or the misfortune through all of COVID through this year of being in a host of different activities on my own with the city or at Drexel with students, non-vaccine services such as testing, such as contact tracing, but then also certainly with vaccinations across the city as well. And I think out of all of those, probably the most beneficial that I have found as an educator is exactly that, is educating our Drexel students in enacting this civic responsibility. And that's kind of where the good neighboring principle for me comes in. The idea of, even early on with testing, and unfortunately, the inequities that we first saw with testing has not necessarily been changed when we go into vaccines. Now, there's a different reasoning behind it, understood. But I think when those of us who have the opportunity to go into communities, not just our Drexel communities, but our neighbors, the West Philadelphia neighbors, the North Philadelphia neighbors, where a lot of the services that we are so privileged to have not necessarily be in any equitable way distributed there. And I think that we can't, and I try to never let that opportunity pass me by, where we can engage our students to learn that it's wonderful that we have this testing center at Drexel, and it's wonderful that our clinical students get to volunteer to vaccinate, but we need to look at the idea of keeping our Drexel community safe as a neighboring principle. So what does it mean to all bring all these wonderful excited freshmen onto campus just a couple weeks ago for the first time, and it's, here we are in February. What does it mean to keep them, and our positivity rate low? It's not just for us, it's for our neighbors. We're bringing students in from all over the country, all over the world. They're very privileged to be here at Drexel, and what we want to make sure that we understand and compel upon them is that we want you to stay safe, but we also want you to stay safe because we want to be good neighbors. There are those of us, who, and many communities that neighbor up to us that don't have all the services that we have. And we need to keep our rates low to help the city and to help those members of our city as well. And then the idea, I think, also of just this kind of idea of self-efficacy as well. So we're trying to impose upon our students and our community that we can make a change. And I think, and this, I'm going to lead off into Ebony's talk now, is that kind of, what does that mean to members of our Philadelphia community that don't have all the privileges that we do and our students do. Dr. White.
Thank you, Kim. Dr. McClellan. So as Molly's pulling up the slides, again, like I said, I'm a clinician by trade, so I'm a behaviorist. I'm very interested in why people do feel and think the way they do. My specific area of clinical work and research and advocacy is around solely Black and African-American populations. So that's what I'll be talking about mostly today, although I do talk about other folks of color as well. I do want to make a correction at the beginning of the presentation. It said I was going to talk about underrepresented minorities. I will be talking about an underrepresented minoritized population. And before I do that, it is February 2nd. And so I want to say happy Black History Month to myself and everyone. And I know that Black history is all year long, but this is our anniversary. Next slide. Cultural mistrust. So I was, one of the things that Dr. McClellan and I and the panelists have spoken about, and Dr. McClellan, said explicitly, is that she's noticing that of the people that she is testing and I believe vaccinating, she's not getting a lot of people of color. And so I just wanted to speak to that behavioral piece, particularly of Black folks. So I want to introduce a term that may be new to some folks, but it's called cultural mistrust. And it used to be called cultural paranoia. And I vacillated between whether I was going to put that first term on here or not, because typically people associate paranoia with something that is unfounded. However, this is something that is founded in history, in fact, and experience. And so cultural mistrust is cultural paranoia in the form of mistrust of whites that exists among Blacks due to past and contemporary experiences with racism and oppression. And that was coined by Terrell and Terrell in 1981. And this research has certainly been extended since then. And so I just want to talk about why that cultural mistrust exists from a social context. And then I'll move in talking about the medical violence that has occurred, which leads into probably the answer to the question that was posed to me. And so it's important to understand that Black people in America, for the most part, historically, those who are mostly American citizens, that we have a very painful story in America. And so there was a kidnapping and enslavement for centuries of African people in America that has largely been unacknowledged. And so there has not been any reparations, there has not been any sorry, and nothing really has been done to rectify that. And then after the practice of traditional slavery ended, we have to remember that there was continued racial violence directed specifically toward Black people, particularly during the Jim Crow era. And something that we all should be familiar with is lynchings that have occurred. And if you are familiar with things like the New York Times, or if you follow online newspapers, you'll see that lynchings actually are still occurring in some places in the South. And then we know the impact of mass incarceration, which was a tactic to keep Black people enslaved. We are very well, or we should be knowledgeable of disenfranchisement. I want to back up a little bit and say that when COVID first hit and they started talking about how Black people were disproportionately impacted, they said because it was their underlying conditions. And I want to say that that was not true, because the true underlying condition is racism and oppression. And so disenfranchisement has happened, for centuries in this country of Black folks. And so there is disparate access to adequate education, so under-resourced, education, when we think about the classroom sizes in urban public schools versus suburban public schools and private schools. When we talk about jobs, and I think a few folks talked about this earlier, people of color, we know that race and economics are closely tied together in this country. And so people of color are disproportionately those who are frontline workers as well. We know that disenfranchisement occurred in voting, especially in finances too. And then we want to talk about I want to talk about disparate treatment in healthcare. And I'll tell you a story later on about that. But we know that when Black people go to the doctor, they're treated very differently than their white counterparts. And there are studies as early as 2017 where first-year residents, medical students were reported that they do believe that Black people experience less pain than white people. So think about what that means for healthcare. So moving on to medical violence. And so there's a long storied history of medical violence directed toward Black people and folks of color as well in this country that is not so far in the past because it has continued. And you'll see as I continue on in the presentation. And so Black bodies during slavery and after were seen as anatomical material. And so it was seen, basically they can do with it what they wanted to. If you're familiar with James Marion Sims, he's really credited for advancements in gynecology, but he did experiments on a lot of enslaved Black women. And we use a lot of his practices today, and those practices or the treatments that he developed that are still in use today, we need to not credit him, but credit the Black women who oftentimes gave their lives for him to experiment on them, and oftentimes without medication or sedation. 20th century eugenics law. And so we know that for a long time, all the way up into the 1980s, that sterilization of African-American, Indigenous, and Puerto Rican women occurred. And so that means that maybe during childbirth or when they went in for a vaginal exam, they were being sterilized without their knowledge. And actually there was a study that came out in 2020 that verified, I can't remember what state it was, may have been California, where women in prison, particularly women of color, were being sterilized as well. And I can find that study and send it to Darren to post as well. The Tuskegee Experiment is a very well-known experiment where Black men who had syphilis and some who were injected with syphilis were untreated even when treatment came out. So they could have just been given penicillin and that was withheld from them. Henrietta Lacks, there is a book about her story as well, but she's a woman who, she died and her cells, when she went in for treatment in Johns Hopkins, actually, her cells were taken without her permission, but it was because of her cells that we have the polio vaccine, that we have some of the treatment we have for cancer and other diseases as well. Also important to note is that this was done without her permission and her family has never been compensated and are still currently living in poverty. And then I want to tell a story about my grandmother, because I recognize that oftentimes when I do these types of presentations and I talk about things that seem maybe historical, that's not attached, that people don't feel it until they recognize that this is not just something that's written in history books, but this is people's actual lived experience. I also recognize that in the Western context, the written word is valued over the narrative word, which the narrative is valued more than the written in African American culture. And so I want to value that. And so my paternal grandmother, her youngest child was sick. She took him to the hospital in Georgia in the South. And this was in the 50s. And she sat in the waiting room waiting for someone to treat her baby, and her baby died in her arms because they refused to treat her. And so this is something that has happened directly attached to me. So when I'm telling these stories, I want you to know that this is not just something you can find in the history books, but these are actual experiences, people's lives. Next slide. And so when we think about COVID-19, we know that racial and ethnic minoritized groups are disproportionately impacted. And I talked about some of those reasons. And I listed them here too. I know we don't have a lot of time left, but when we think about healthcare access and utilization, right? And so where are the hospitals? And I know Philadelphia is probably unique when we think about most urban cities, right? And so there's a lot of hospitals. And I know some have closed down in the city of Philadelphia. But when I think about where I grew up, the hospitals really weren't in urban environments. And if they were, they didn't have good reputations. And also, oftentimes people would wouldn't be believed about their pain. If you didn't have certain insurance, you couldn't be seen. And so there are a lot of issues when we talk about healthcare access and utilization. I also want to talk about how access is different than availability. And so just because something is available, it doesn't mean that it is accessible, right? And so even if there is a hospital, say around the corner from my house, do I have access? Even if there is a doctor's office in my neighborhood, do I have access? Meaning, what are the office hours? Is it interrupting with my work hours, right? If I can only go to the doctor at a certain time, I can't take off work because I don't have PTO because I'm a frontline worker and we don't get those, right? And so it's important to understand that. Occupation, I already talked about how people of color tend to be disproportionately represented in frontline occupations. I talked about the education, income, and wealth gaps. And also when we think about how housing, and you can look at Philadelphia for this, is very closely populated. And so it is difficult to physical distance in a way that you can, particularly when you have multiple generations residing in the same household. Communities are very close-knit. And then finally, I want to talk about how discrimination is really the issue that has impacted treatment in minoritized communities, because they tend to receive a lower quality of healthcare. When we think about the opioid epidemic, and we know that white folks are largely those who are impacted by the opioid epidemic, we have to ask ourselves why. And the reason is because largely a lot of folks became addicted to opioids because their doctors prescribed it to them. And so if their doctors were prescribing it, then it would seem like if healthcare was equitable, everyone should have developed this issue. And so I don't want to say that I wish Black people had an opioid issue. What I'm saying is it goes to show you that it's proof that Black people weren't believed about their pain. So they were seen as not telling the truth about their pain. And also they were seen as higher risk for developing addiction as well. And so doctors decided not to give opioids to African-American people. I already talked about not being believed about their symptoms. And then I also want to share this story. I am an advocate and an activist, and I truly support the movement of Say Her Name. And I want to say Raina Zoe Mungin's name, who was an African-American woman, 30 years old, and she was going to UMass Amherst. And she went to get COVID tested several times. This is last year. And she was denied COVID testing on 2 occasions, and she's no longer here with us. She ended up dying of COVID. And I think that story is important because that happened last year to a 30-year-old African-American woman. If we were thinking about Deb Clegg's slides earlier and seeing that the risk of mortality is higher the older that you are, and that the risk of mortality for women is lower. And she was a 30-year-old African-American woman who died of COVID, and that didn't have to happen. Last slide. And so I'm going to end with the question that was posed to me: why are Black people apprehensive about the vaccine? So I think that I no longer now have to answer that question, right? I think, you know that there's this storied history that has occurred. And I even heard people say things to me like, how do you know they don't have certain vaccines that they're given to Black people versus white people? And that's how deep rooted it is, because these things really happened in our histories and in our past, and even in our present. Black people, because we've now, read, and now we have higher education, we've been told that it takes, years to develop a vaccine. And this vaccine was developed in less than a year. And so there's mistrust about that as well. And then when we look at who's administering the vaccine, people don't look like us. And so we don't believe that they have our best interest at heart. And so there is work that we need to do around that. And so if you have any questions, you can put it in the chat.
Fantastic. Thank you guys so much. So we are open for questions and dialogue. I think that was amazingly powerful. And thank you all so much for your insights. I haven't seen any specific chats for it or specific questions in the chat. So I will be quiet and see if there's anyone wants to bring up a question. So I'll take it. So Ebony, phenomenal information. So how do we address that? How do we, right? What's the next step? I don't know that you have an answer, but I'll throw it out there for sure.
Yes, no, absolutely. And so, one of the frameworks I use for most of my work is ecological systems theory. And so a lot of times we talk about micro and macro, right? But we don't talk about the in between. And the truth is things have to happen at every level. Um, and I think history has shown that the people who are oppressed are the ones who are screaming, and that approach hasn't worked. Right. And so there's a lot of people, like, even when we think about the racial pandemic that's going on, and now all of a sudden there's a lot of white people saying, what can we do? We didn't know, even though there is centuries of documentation that this has been happening. And so it really has to be top down. And so I definitely believe there has to be an acknowledgement of racism in America. And I know that the CDC has acknowledged, the impact of racism on folks, that racism is traumatizing, right? And that it is bad for physical health. But I think that people often stop at saying it. So we need to acknowledge it and then do something about it. At every level. And so even in our curriculum, I'm an educator, so I'm always going to go to curriculum, think about what we're teaching our students, and think about personally, now back down to the micro level, think about personally when you are in your classrooms. I mean, now we're in virtual classrooms. Are you unaffected by the demographic makeup in your classroom? Particularly being in a university that's situated in a city that's almost 50% Black. Right? Oftentimes I go into my classrooms and I am the only person of color in my classrooms here. And that's problematic. And that reinforces who's going to be our doctors, who's going to be our nurses, who's going to be our clinicians, right? And so we have to be intentional about recruiting and retaining students of color. And then, my hope is that people or organizations are mandating the type of training that keep their professionals in check, right? And that they have fail-safes in place so that if something is missed, someone can go behind them and make sure, and try to root out the racism in practice. Yeah, absolutely. But there's a lot that we can do, and there's a lot published about what we can do. I know Dr. Waite is always sending out things to read in action steps as well. So I encourage people to look into those things as well.
Yeah, I think it was so important. And even the demographics of that article I demonstrated from New England Journal, I mean, look at that. I mean, it just screams exactly what you just said, right? And so we really need to make a full court effort to incorporate people of all color in these trials. And that's going to be really, really challenging if they don't trust. It's very, very understandable why they wouldn't, right? Yeah. Any other questions? All right, I think I don't see any for now, so.
Hold on, Jess Ballinger just posted.
Ballinger.
Jess, you want to turn your microphone on and raise your question or your comment?
Sure. First of all, fantastic presentation. And I think you've given us a lot of really great ways to think about these vexing issues of distribution. I just wanted to raise a kind of a different set of concerns, and it has to do with production. These vaccines are private property, intellectually protected. That is certainly going to limit the productive capacity to the companies that can produce it or that they're willing to license these to. And I wonder if there is a ethical, given that we're not vaccinating people at the rate we need to because of a lack of supply, because of shortages, and we are facing, global distribution around the world with other countries, is there a case to be made that these vaccines should not be treated as intellectual property the way pharmaceutical products typically are?
Fantastic question, and thank you. Connie, are you able to take that one?
Sure. I mean, it has so many different areas, but one thing to recognize is that most pharmaceutical companies are building on research that was publicly funded. So,
that's even more so in this instance.
Yes.
Moderna took literally, I mean, I love what they've done. It's their incredible,
right,
triumph. They risked zero of their own capital in this? Zero.
Right.
And
So,
AstraZeneca wanted to make it publicly available, and the Gates Foundation talked them into privately licensing it to them, which is like,
Interesting.
yeah.
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 The and you know, I've been wondering how and I feel a little bit better given that Johnson & Johnson's effectiveness for their vaccine is going up with a booster later on, but to then say, okay, well, you know, Pfizer and Moderna's vaccines are virtually 100% effective at keeping people out of hospitals, but you know they're dainty because you know they have to be kept frozen. So you know, as Sharona mentioned, the global South, you know, we're going to give them the Johnson & Johnson vaccine, or you know, but if that's less effective, is that, you know, you're giving a second tier level, you know, so I feel a little bit better that the booster shot will bring that vaccine up. But I do, you know, the Moderna's argument that, well, we're just keeping back the, you know, a supply for us to distribute as we want, you know, to our friends and family. That's bothersome because it's really not their it's not their private property in the sense that that it would be if they created it on their own, but they use public funds and public support in order to create this, and that has to be acknowledged, you know, even if you argue from a strict property rights perspective.
Stephen, did you have a question, Stephen?
I didn't.
Okay.
Oh, did I raise my hand in
No, I just saw you unmuted and I was like, oh, he's going to jump in. No, and Jess and I had talked just briefly about the global impact of this, right? So all of us maybe who are living in the United States will have exposure or an opportunity to get vaccinated, but people who live in third world countries are not. And so there's a whole nother level of ethics that are all associated with the global impact that this is now going to have. And it's frightening. And that hasn't really even been addressed, not in the media that I've seen in any way, shape, or form. So very, very frightening. So thank you again. We're going to stay around for a few minutes. I know we're over time. So if anyone has any additional questions, we're here for you. And just, you know, let's keep together as a community and talking about this, because I think that's the way we'll become educated. So thank you.